Welcome, everyone. Thank you for joining us today. This is Natasha Bonham, Vice President of Strategic Development at Genetic Alliance. This webinar is part of our Genetics Day on the Hill series. Genetics Day on the Hill will take place at the Reserve Officers Association on Thursday, June 23rd. We hope to see you there. On that day, Genetic Alliance will be discussing 3 topics, one of which is providing crucial initiatives that protect and support the health and well-being of individuals through the lifespan, particularly through the CDC programs for birth defects, disabilities, and public health.
Today we have Dr. Gloria Krahn,
the Director of the Division of Human Development and Disability at the National Center on Birth Defects and Developmental Disabilities. Previously, she served as President of the Association of University Centers on Disabilities, Chair of the Disabilities Section of the American Public Health Association. She has also served on the Executive Committee of the National Association of Rehabilitation Research and Training Centers, and as a leader of the Healthy People 2010 Disability Work Group. Is widely regarded as a national and international expert in the field of disability and public health, and we're very happy to have her joining us today. So without further ado, please take it away.
Thank you very much for that introduction, Natasha, and I'm really pleased that we have the chance to share the work that we are doing at the Centers for Disease Control and Prevention. I'm going to be talking in my role as a federal employee and working to describe the work that we're currently doing here. What you should see now is a note on what you'll learn today from this particular webinar. We really have 3 take-home messages for listeners. One is that there is a unique public health role for rare disorders, including genetic disorders and complex disabling conditions. The second is that CDC has recently adopted and is using a life course model to look at rare disorders and complex disabling conditions. And then third, we want you to have an understanding of the funding and the funding strategies that will impact our work. This slide really tells you about the history of the National Center for Birth Defects and Developmental Disabilities. It was established through an act of Congress, the Children's Health Act of 2000. This is the only center within CDC that is created by an act of Congress rather than from within CDC itself. That act contained language and funding lines for some specific conditions that include Fragile X syndrome and spina bifida. Shortly after the NCBDD was formed, Congress also funded the Muscular Dystrophy Community Assistance Research and Education Amendments of 2001, which is often referred to as the MD CARE Act, and this was then reauthorized in 2008. The language and intent of these multiple acts led to the development of a focus on really the national epidemiology relating to disabling or potentially disabling single gene disorders that are complex and disabling. The collection, analysis, and reporting of data for example, the purpose of carrying out epidemiological activities, which is language from the MD CARE Act, addresses Duchenne-Becker muscular dystrophy, which is the most prevalent of muscular dystrophies, as well as addresses Fragile X syndrome. These were the first 2 conditions that were addressed, with efforts focusing around surveillance, research, and broad education. Now, while it was authorized in 2000, the funding for the work on spina bifida wasn't provided until 2003 with passage of the Birth Defects and Developmental Disabilities Prevention Act of 2003. And that legislation added a national spina bifida program within CDC to prevent and reduce suffering from the nation's most common permanently disabling birth defect. That's language directly from the Act. Now, single gene disorders have inheritance patterns that can guide genetic counseling and research. And we recognize the need to identify both cross-sectional and longitudinal data that's associated with children who have these and other conditions, and the need for following children with these complex conditions through transition and into adulthood. So that's the historical background. I want to show you now where we're located within the federal government. You see we are within the federal government, And within that, we reside within the Department of Health and Human Services, which is directed by Kathleen Sebelius. That also contains the Centers for Disease Control and Prevention, directed by Dr. Tom Frieden, the National Center on Birth Defects and Developmental Disabilities. Recently appointed director of that is Dr. Colleen Boyle, and then the Division of Human Development and Disability, which I direct, and within that, the Rare Disorders and Health Outcomes team. The Division of Human Development and Disability, as part of the center, engaged in strategic planning recently, and that plan is guiding our work into the future. This division developed 5 priorities, and the work on rare disorders and complex disabling conditions helps us meet the intended outcomes of 3 of these priorities. Those are the priorities that are highlighted on your screen. They are to improve developmental outcomes of children, to reduce disparity in key health indicators, including obesity in children, youth, and adults with disabilities, and to identify and reduce disparities in access to health care for persons with disabilities. So what is our funding? For the division, we currently have 11 different funding lines. Many of them are directed to specific conditions and activities. In fiscal year 2011, that budget just came down a few weeks ago, the agency was required to absorb an 11% reduction in its base budget from the FY 2010 funding levels. Now, every part of CDC experienced budget reductions for FY11, including our center. In the final NCD-DDD operating budget is reduced by $7.5 million down to $136 million for FY11. This reduction included significant across-the-board budget reductions as well as the elimination of some specific programs. Those programs included Charcot-Marie-Tooth disorder, alveolar capillary dysplasia program, and Diamond-Blackfan anemia program. These reductions resulted in our center's operating budget reverting back to FY 2008 levels. We had a series of criteria that we used to determine what reductions we would take, but that has been the bottom line result. For the President's FY12 budget, it calls for a consolidation across our multiple funding lines. So it would essentially take the current 11 funding lines and consolidate them into a single line. Now, reflecting the center's commitment to gaining partner input on this proposed budget consolidation proposal, we've hosted a series of calls and meetings with funded partners over the past several months. This division, our Division of Human Development and Disability, hosted 2 in-person partner meetings in April and in May. And during those times, we shared draft copies of a transition plan that indicated how we would approach this process. Fundamentally, if we had the 3 years of transition and transition funding, it would mean that virtually all current awards would continue, and we would then roll them into consolidation efforts as awards come to an end. The new approach, and this is being used across CDC, would use consolidated funding opportunity announcements, such as a single funding opportunity announcement for a number of distinct public health practice and resource centers, each focusing on a different population. Now that takes us through the FY12 planning, and that decisions on FY12 will be moving now forward to OMB and Congress. But at this point, FY13 planning is happening, and decisions have not yet been made about other potential cuts for that year. So that's the background on the funding and the funding as we know it as of today. Let me now move to a description of really the work that we do given this history and this funding. This slide shows you the life course perspective that our division takes for people with disabling conditions. And I will not go into all of the categories of this work, but primarily I want to emphasize that the work spans the life course and that we are working to build synergies across these different efforts. Our approach has been to think and work across disabilities where we can and to use a condition-specific approach where we need to. And we know that with some of the genetic and complex disabling conditions, we know that we need to be more condition specific. So these diverse efforts are influenced by a life course, really a conceptual model that I'm going to show you in this next slide. So this is a fairly busy slide, but this model, which was developed by Mark Swanson and the Spina Bifida team, is being used by our division. We think it's a really valuable framework for much of the work within our division, including work on genetic conditions. It's essentially a logic model that's based in the International Classification of Functioning Disability and Health, the framework that the World Health Organization developed a decade ago. On the far left side of this graphic, it depicts the body functions and structures, and then on the far right, where we're trying to get to, is participation and quality of life. And then in between are the types of developmental tasks that are needed at different life stages, from preschool through school age and adolescence, and on to adulthood. It looks at three core life areas of health and self-management of health, of personal and social relationships, and of education and employment. And all of this occurs within the context of the family environment and personal factors such as demographic and cultural characteristics. We're seeing a fair amount of interest in this model in the field, in part because it's a very practical way of reminding us about the multiple areas that constitute our lives and the need for attention to all of these areas in leading to adulthood and full participation. Our overall approach is reflected in this slide, and over time we've really broadened the work on single conditions to represent more of a public health approach and to be applicable to other complex disabling conditions, many of which also have a genetic basis. The work within and across these conditions can generally focus on one or more of the following. The first would be identifying and monitoring how many children or people have a condition, which is called surveillance and is often used to document the impact of need across the country. The second is to identify risk and protective factors. What does the condition relate to, and what predicts to better or worse outcomes for someone with this condition or for their family? That's often referred to as epidemiology research. The third is what interventions are effective in improving outcomes. We talk about that as intervention research. And the fourth is who needs to know this and how can they be reached? And that's where public health practice and resource centers come into play, as well as communication, as well as work on policy. Now I'll illustrate this approach with the three conditions for which we receive directed funding. So that's the next part of my presentation. Here's the first slide, speaks to muscular dystrophy. And we've been funded since, at CDC since 2002 under the MD CARE Act. Duchenne-Becker muscular dystrophy has been studied in clinic-based populations previously, but there were no population-based studies in order to more accurately describe the number of people who have this condition, the course of the condition, and the type of care that's received by people with Duchenne-Becker muscular dystrophy. A program called MD StarNet was created as a population-based surveillance system that tracks individuals with Duchenne-Becker muscular dystrophy that reside in 6 sites across the country. This data set currently includes 880 people with Duchenne-Becker muscular dystrophy, with 220 of them coming from racially or ethnic minority populations. Now this work has been going on for almost a decade and has resulted in the following. First, we've confirmed the need for earlier diagnosis, that there is a diagnostic delay that has not changed for the past 20 years. Whereas first signs of Duchenne-Becker muscular dystrophy show up at an average of 2.5 years, diagnosis is not happening until almost age 5 on average. We've also established that the occurrence of Duchenne-Becker muscular dystrophy is somewhere between 1.3 to 1.8 per 10,000 males within the age category of 5 to 24 years. Third, we've established the need to monitor adult care as more people with Duchenne-Becker muscular dystrophy move into adulthood. There's much more needed around knowing what care is occurring. And finally, there's achieving a better understanding of these issues will help researchers, healthcare systems, and policymakers into the future and improve the lives of individuals affected by Duchenne-Becker muscular dystrophy. Our next steps going into the next number of years are to determine how to identify this condition earlier, to determine the feasibility of collecting data on other muscular dystrophies. We've used and developed a fairly complex system for identifying all cases and then tracking care and tracking outcomes, and we want to see how well that would apply to a number of other types of muscular dystrophies. And finally, we want to extend the analyses and publish more on the data set that has already been collected and collected so carefully and at considerable cost over the preceding years. We see this as a real investment for the future that needs to be harvested. Now, with respect to care for muscular dystrophy, we've also looked at the variability of care for people who have this condition. Although there have been guidelines available for different parts of managing Duchenne muscular dystrophy, there were no comprehensive clinical care recommendations. So a number of years ago, CDC convened an international group of clinicians to develop care recommendations that would be based on the best scientific evidence available combined with clinical expertise. This has been a multi-year effort with the working group evaluating multiple scenarios of assessments and interventions that are used in the management of Duchenne-Becker muscular dystrophy. This work resulted in a set of recommendations that were published in 2 parts intended for a wide range of practitioners who care for people with Duchenne muscular dystrophy. These care considerations now provide a framework for recognizing the primary manifestations and the secondary complications of the condition, and for providing coordinated multidisciplinary care. So in addition to those 2 publications for a care professional audience, and those papers were published in Lancet Neurology, we have also developed a family-friendly version that is now available in 18 languages and has been distributed worldwide so that families and individuals with Duchenne-Becker muscular dystrophy are also familiar with what the care considerations recommend. Our next steps are to evaluate changes and in practice and in outcomes following the release of these care considerations, and then to continue to address the barriers to improved care and earlier diagnosis for Duchenne-Becker muscular dystrophy. So that's the work on muscular dystrophy. Let's move to spina bifida next. In 2005 and 2006, there was a survey of spina bifida clinics, and it identified great variation in care across programs, in the structure of the clinics, in the services provided, in the type of staffing, and ultimately in the patient care. The National Spina Bifida Patient Registry is now tracking variations in patient care in order to create an infrastructure for a systematic approach to support clinical research and to improve quality of care. It also compares patient care among clinics and across areas, and it will guide future spina bifida research by identifying areas of needed priority. Now, I want to make note that this registry is not population-based. Instead, it was based as a network of spina bifida programs that successfully competed for funding. While a population-based approach would have been ideal, we determined that the cost of doing that and with getting comprehensive data on all participants just was not feasible or practical. To date, we're tracking health data from 9 clinic sites for over 1,500 persons with spina bifida. We've been very successful in that approach, and our next steps are to analyze the data in order to describe current clinical practices and to expand the program to another 8 sites that have expressed their interest and willingness. The next slide speaks to some of the communication efforts that we've been engaging in spina bifida. There's been substantial input on the importance of promoting independence for children and youth with spina bifida from family members, from advocacy organizations, and from persons with spina bifida. So we have taken that information and we've blended that with a life course model and are now making it available to a wider audience through our website. The importance of health self-management, building personal and social relationships, and education, learning, and employment became a section entitled Living with Spina Bifida on our website, and in tandem, the Spina Bifida Association created an interactive website called Preparations, and that allows searching by age or by topic. Into the future, we'll continue to update the website, we'll continue to develop and provide information, and we'll continue to fund other studies that look at what are those factors that influence outcomes by applying a life course approach to spina bifida and hopefully other complex disabling conditions, with a continued focus on the importance of adolescent transition to adulthood. I'm going to move now to our work on Fragile X syndrome. The purpose of the Fragile X Consortium and Registry are similar to those of spina bifida. They are to standardize and ensure appropriate care and to collect information over time about people living with Fragile X. And for Fragile X, the issues focus on behavior and learning for the most part. This information will be used to determine the public health needs of people with Fragile X syndrome and to ensure that the public health needs of people with Fragile X are met. Beginning in October of 2000 and continuing up to the present, a Fragile X Clinical Consortium has worked to develop standardized referral and intake processes and continue work towards developing consensus on what the basic practices and standards of care should be. This project has facilitated increased communication between professionals who have skills in evaluation and treatment of Fragile X syndrome and professionals who are practicing across the country. The consortium is developing a patient registry and database and a standardized database module for data collection. So you can see that the Fragile X syndrome is using the methodology developed by Spina Bifida and now applying it and adapting it and applying it for their own needs. Additionally, this group has created a research review process that will allow other researchers to apply to access the data and the participants. Now, the work on the registry is still early, and next steps are to add more individuals to the registry and to determine the best practices for care among people impacted by Fragile X syndrome. Earlier work on Fragile X included a national survey of 1,200 parents that was fielded to focus on diagnosis, treatment and services, family support and communication, transition to adulthood, and adult needs. The survey yielded several very important findings. The first is that despite increasing information about the condition in pediatric journals during the years that were surveyed, which were 2001 to 2007, the average age at diagnosis for boys without a family history of Fragile X was relatively stable at 35 to 37 months, or roughly at about 3 years of age. Now, approximately 1/4 of these families had another son with Fragile X before their first son was diagnosed with the condition. A second important finding has been that there are co-occurring conditions that are frequently reported for all people with the FMR1 gene variation. The results emphasize the importance of including an assessment of co-occurring conditions in any clinical evaluation of individuals with abnormal variations in that gene. Now, almost half of the families affected by Fragile X reported that they had experienced an increased financial burden, and nearly 60% stated that they had to change work hours or stop working because of issues relating to having a child with Fragile X. Co-occurring conditions are associated with both financial burden and employment impact. Policies designed to help families with Fragile X need to take into consideration the dimension of co-occurring conditions. The next steps for this work is a plan for phase 2 of the Fragile X Family Survey that will expand knowledge of the nature and the consequences of having Fragile X, and will use that information to inform clinical practice and policy development. The project will recontact and will expand the current survey sample. We'll focus on recruiting families from ethnic minority and families of recently diagnosed children. Phase 2 will also involve a more comprehensive survey and will use the internet and call center capabilities in order to field the survey. Once the second phase of the survey is complete, we'll analyze and disseminate the results of the survey, and those findings are anticipated to guide future work. So in summary, we think that there is a unique public health role for rare genetic disorders as well as other complex disabling conditions, and we think that role is different from that of bench research or specifically clinical care research. A public health role addresses surveillance in identifying the prevalence of a condition, the age of diagnosis, and the work that's needed to identify methods to reduce the delay to diagnosis. We also think it includes developing a system for understanding how clinical care and other services relate to improved outcomes, as well as understanding how to live well over one's lifetime with one of these complex disabling conditions. And finally, we think it has implications for policy to increase attention to the needs and the solutions for persons with conditions like these. The results to date from this work is that we have developed new knowledge on prevalence, on delay in diagnosis, on recommendations for care, and developing new longitudinal methods on linking care to outcomes. Into the future, with funding, our programs will advance knowledge and methods not only for these key conditions, but also for broader application to all people with other disabling conditions that have effect across the life course. Thank you very much for the opportunity to talk with you, and I'm open to questions if you have.
Great, thank you so much. I don't believe we have any questions. You are very thorough and went through all the different pieces that we needed very nicely, so thank you so much. Again, to everyone listening, our Genetics Day on the Hill will take place on June 23rd, where looking at CDC programs will be one of the 3 issues that we talk about during that day. Again, thank you very much to our speaker, Dr. Krahn, for all your hard work in this area, and we look forward to seeing everyone on the 23rd of June. Have a great day.